Okay, good afternoon, everyone. I'm Bill McAleer with Voyager Capital, and I'm going to be leading a panel session today on digital and computational health. This is a sector that's literally exploding with growth, and Seattle is one of the key areas for the growth in this whole sector. This is a sector that has seen a lot of acceleration as a result of both the pandemic, but also the application of cloud computing, telemedicine, and AI technologies to the overall healthcare sector. We've seen significant capital invested into the market sector, with something like 45 billion invested in the past 2 years and 30 billion in 21 alone. Well, ideally, all this spending and innovation will ultimately enhance individual and population outcomes, improve patient care, and optimize, ideally, the clinician-patient interactions. I've assembled a great panel today to explore the latest opportunities and trends in this space, and I'd like to introduce several of them to you today. First, if you look up on the tiles here, Mike McSherry is going to be joining us. And Mike is the CEO of Xealth, spelled Xealth, a company that he co-founded. And prior to founding Xealth, he started several companies, including Swipe, a company we wish we'd invested in, which was ultimately sold to Nuance. And he spent a lot of his earlier career in both software and mobile. Xealth provides a digital health platform for clinicians to prescribe and monitor health solutions. And they work with over 20 of the biggest systems in the country and integrate into all the major EMR systems. Second up in your tiles is Sara, Vaezy. She's Senior Vice President of Digital and Growth Strategy for Providence Healthcare. Some of you may know they're the third largest nonprofit system in the country, with 25 billion in revenues and some 25,000 physicians under their network. As she says, she likes to see her role as helping steer a larger organization to digital transformation. And she looks at emerging technologies and some of the innovations that are occurring in the space. And then our third panelist is Raj Singh, and I've known Raj since he was the CEO, or I guess the number 2 guy with Steve and founder of Concur, which was sold back a number of years ago to SAP for about 8.3 billion. He then went and founded Accolade and really moved his career from what was largely a software focus into digital healthcare. And Accolade helps provide personalized healthcare, providing people and their families access to ideally quality primary care and benefit services. They like to say they are data-powered and people-centric. The company went public in 2020, and they raised about 220 million as part of that offering. So welcome again, everyone. And what I'd like to do is dig into some questions with the panel. And we're going to explore some of the areas that are hot and interesting and innovative in the digital health space. The first question I'd like to pose, and I'd like Raj to start out here, is let's talk about what we see as a couple of key trends that each of you are seeing in this space. And Raj, maybe you could kick it off, and then I'd like to follow with Sara and Mike.
Fantastic. Well, first of all, Bill, thanks for having me. I appreciate it. I appreciate everyone being here at this session. When you think about healthcare, speaking to trends, when you think about healthcare and the enormous amount of information that's available about every disease state, or the enormous amount of information that's available about individuals, whether that's their gene pool, their DNA code, whatever it might be. There is extraordinary amounts of data available to us about every individual that the healthcare system is trying to treat. And yet for whatever reason, most often primary care physicians or physicians in general are presented with with a tiny fraction of that information when they have an opportunity to impact a person's care. And so our opportunity to create platforms for data, and whether that data is taking the claims data that the insurance companies have created, taking electronic medical record data that's been created by health systems around the country, or other third-party data sets that exist today, and assembling a 360-degree view data set of that individual, the opportunity to do something along those lines is really pronounced and very real today. And so whether it's companies like Accolade assembling that on behalf of our customers, Jonathan Bush has a new startup called Zeus. There's another company in town, Terry Myerson's created a company called Truveta that's doing some work with Providence. There are a proliferation of platforms being built to help assemble the data necessary to take care of people. And that leads to what I'd call the second trend. And that second trend is the idea of personalization. Once we have that information, can we use that to stratify populations? Can we use that to identify the needs of any given population and then guide their care in the right direction? Those two trends, in my mind, are fundamentally the drivers of what's a possibility of greatly improved outcomes in the future.
Thanks, Raj. Sara, do you want to comment on what you're seeing from the Providence perspective, which is a pretty broad swath of the industry?
Sure, absolutely. And thank you for having me. I couldn't agree more with Raj's comments, and the way that we think about it is really around this notion of consumer identity-driven personalization and engagement. And that is a major trend that has all sorts of offshoots of things that we can do, whether it be engagement. So once you have the 360, right, it can be engagement around a clinical episode of care. It can be engagement around non-clinical things that influence health and wellness, or simply just the relationship and the stickiness between an individual and their provider. It could be targeted marketing of services that are relevant to them. One of the examples that we're actually doing is we can understand now when folks are on our websites searching for information about knee pain or knee replacement, and then do proactive outreach to them in a targeted outbound fashion, rather than just sort of spray and pray type of old school marketing. So that consumer identity driven engagement is really going to be, from a digital, consumer digital perspective, transformational for us. And there's, a lot of interesting work that we're doing around, for instance, how do you do identity federation so that folks don't have to log into each of these different places where they have some sort of health related relationship and account with different logins, right? And these things may seem somewhat tactical, but actually they're very strategic and very sort of transformational when it comes to consumer digital digital transformation. One other thing I'd be remiss if I didn't mention, given that I'm within a health system, I'd be remiss if I didn't mention the huge amount of pressure that the workforce crisis is generating within healthcare, and the things that can be done from a digital transformation perspective to alleviate that, or to at least support clinicians. We're never going to have enough clinicians, just as a matter of supply demand economics to serve the demand that we have. And that's a huge trend. It was accelerated by probably 5 to 10 years with COVID. We're doing that trend is forcing us to get a lot more serious about things like digital self-service. So things like booking yourself an appointment as opposed to having to call into a clinic, simple stuff that we take for granted, frankly, in other parts of our lives. But they're really material challenges in healthcare. Clinical support for clinicians, like providing the data that Raj referenced at the point of care so that folks can actually make real-time informed decisions. automating rote tasks in the background, so that we don't force our clinicians to do that. So that trend around workforce and the technology that can support our workforce in different ways is another big one for us.
Good. Hey, Mike, what do you think? Are there any couple trends that you're
obviously agreeing with the prior two comments and the foundational layers that they're talking about? I'd sort of frame it up in maybe three broad dynamics. There's the consumerization trend of patients, and that's not to say they're the best shoppers for care, but they want choice, whether that's telehealth or face-to-face or easy clinic access, or a quick and convenient or a longitudinal relationship. But regardless, there's increasingly patients and people seeking health behaviors and changes and solutions will want things that meet their needs. So the fragmentation of what the consumer wants is out there. Second is just the incredible rise in healthcare costs and inexorable, year after year premium increases, et cetera. The government is forcing, cuts in reimbursement rates. That's forcing everyone to get more efficient, deliver better quality care, lower cost, holy grail of, the triple aims scenarios. And that's pushing towards more automation. As Sara had referred to, healthcare for the last 10 years has been the highest growth industry in terms of labor. Just year over year, hire more nurses, more MAs, more nurses, more MAs. They can't hire them now. They've lost them. They have to move to automation of processes and self-service. Think cashiers and banking. Everybody does self-service in those. So to the extent that you can drive consumer behavior in self-service manners, you're going to look at cost cutting against that framework. And then it would be remiss to not mention the competitive dynamics that are being out there. CVS, Aetna stacked up a retail play and payer Optum's out in the market buying and building nationwide solutions with their aggregate national revenue scale that is changing dynamics. And then you've got big tech, Microsoft and Oracle announcements on Nuance and Cerner. And that's waking up everybody's eyes that they have to do something. There's no longer, let's just continue to hire bodies and do care the way that we have been for the last number of years. COVID vastly accelerated all of these shifts, and nobody can just sit still. You have to make decisions and advance, and that you're either leaning forward or you're leaning backwards in the way that the world's quickly evolving.
Great. So it sounds like there's some interesting opportunities in personalization, some interesting opportunities in, how do clinicians be more efficient? How does that impact the ability for the healthcare systems to staff? What all of these are interesting areas, but what could each of you maybe comment on? What have you seen where there's been an impact, where there's actually been some impact on the value chain or some impact to the patient or the clinician, someone in that value chain? Just as an example, I think it'd be interesting to get a little more specific about where has something changed and gotten better. And Sara, maybe you could kick that off, since you're seeing that, from almost a platform's maybe the wrong way to characterize it. It's certainly a more macro view as a provider, healthcare system.
Sure. Mike referenced his first trend around consumerization and the desire for people to have choice. And we kind of got specific about this problem around consumers, especially around low acuity types of more shoppable care. And not all care is shoppable, but for the types of care that were shoppable and less, I would say, clinically complex, choice matters around convenience, modality, availability, these types of things. And we actually, at the beginning of COVID, this became very material when we had to shut down all of our physical low acuity, like retail medicine settings, and shift to virtual only settings. And we had built a platform that could do kind of three different things. One was to understand what folks were looking for in terms of care. And we were able to extend that when we were able to reopen our physical settings to kind of this multimodal view of what was available to the end user. So we called it demand aggregation. What are folks searching for out on the internet, and then match what they were looking for to an actual form of care, whether it was a physical appointment or a virtual one. And in some cases, we even were able to do triaging simply with chatbot to do screening and triaging of symptoms and things like that. And then finally, matching, essentially directing folks not just to like the most appropriate from a clinical perspective, but to places that actually had capacity. So that this notion of supply and demand matching, you don't want to point a consumer to a place where they can't get in. Right, that just defeats the purpose. And so we actually built a platform that was spun out into a company called DexCare last year. But that has yielded a lot of results for us. It was really important in terms of patient acquisition. So 30% of the folks, this is even pre-COVID. I think the numbers have changed significantly over the last couple of years. They have, partly because we were able to expand the payer types that we were able to see through this platform. But before COVID, 30% of the folks that came in through this were new to us as a system. They had never received care within Providence. They were maybe getting care in a completely fragmented sort of these kind of spot like point solution type things. We were able to actually build connections with those people and provide downstream services to them when they needed it. And so it was like the notion of getting the right kind of supply to the demand in the way that they needed it, as opposed to forcing them to come to us in the way that was most convenient for us. So that's one example of something that we did that has worked really well for us as a system.
Okay, super. Mike, any thoughts from your perspective? You're dealing with these systems and wondering healthcare systems.
Yeah, well, I'll go back to a little bit of how we responded to our provider customers during COVID. And so we manage the digital health formulary for hospital systems. We've integrated 50 different things that hospital thinks relevant for patient care, from content catalogs, articles, and videos to apps, maternity care, diabetes management, behavioral health, to devices for remote patient monitoring, and then just more broadly, services like meal delivery and transportation. So when COVID first hit and everybody needed to immediately transform to remote care, most people didn't have patient portals. Large percentage of hospital system patients use hospital system infrequently and don't necessarily have patient portal. But telehealth was a requirement of logging into the patient portal to initiate the telehealth experience. So how do you even get people to know how to log into a patient portal? And then it was RPM around, hey, you might have COVID, but unless you're have elevated pulse ox rates or drop in pulse ox rates or elevated temperature, you don't need to come in. So then there's remote patient monitoring against COVID positive or suspected positive patients. And then how do you quarantine those patients home? So we're doing a number of Kroger quarantine kits for patients to respond at home. And then it manifested itself towards this massive rise of telehealth, but how do you remotely monitor or assess someone? So RPM against everything, remote patient monitoring. Every single pregnant mom all of a sudden started getting a blood pressure cuff and a scale, so that healthy mom checkup could be done remotely. Same thing in diabetes, same thing in N number of other, behavioral health was a massive growth during all of this. That's a sustaining transformation here, where now all of those solutions are in place. They're finding they're cost effective and beneficial, and whether or not that patient comes back in for face-to-face visits or not, you now have this asynchronous remote patient monitoring capability against patients with maintaining a 24/7 view towards their health, and then the data that stems from that. And I think that's where we're at now is there's no questioning of the need for it. It's just how quickly in the prioritization against different disease states and management that are going to follow up with a digital health component towards the care delivery, and how that fits within the traditional provider operations.
So it sounds like some of these remote devices were actually enabling that monitoring, and that's a fairly new development in terms of mobile devices having a tie-in to the health system. Is that fair?
Yes, exactly. But you're also hitting into some of the broken, fee for service versus, insurance capitation risk there. Unless hospital systems are getting reimbursed for the care that they deliver, they presume to deliver the cost of delivering that care. It's hard for them to economically justify doing that. And the benefit to a lot of these, chronic care management, remote patient monitoring accrue to the payers, the insurance companies, and employers. And so that's one of the chasms that need to be crossed over here.
Yeah.
And where providers are in their fee for service to fee for value kind of migration, and assuming risk and shared collaboration with employers and payers and others that share insurance risk across this country.
Okay. Raj, obviously you're focusing on this part of this is a personalization element. And could you maybe comment on what you're seeing? Is there an impact that you've seen? And also there's a question in here, in the audience, and we may work it in here. How does this whole notion of personalization work as it relates to HIPAA? Maybe you could also amplify on that a little bit, since it sounds like you all are trying to do more tailored, target of the provider, I guess, in this case.
I think both Sara and Mike had on some points here as it relates to how to think about healthcare and where innovation or opportunity exists to dramatically improve things. And I think a part of that story, and Mike referred earlier to this idea of the triple aim. The triple aim, for those who aren't familiar with it, the idea of, can we improve clinical outcomes? Can we make people healthier? Can we do it while lowering costs? Because we spend more on healthcare in the United States, oftentimes with subpar outcomes, than any other OECD nation in the world. Can we find a way to reduce costs while improving outcomes and driving patient satisfaction? Can we make that person, in this idea of consumerization that both Sara and Mike talked about, can we drive a patient experience that's superlative? And there's more to it. Even if you think about, there was recently an article in JAMA that spoke to, it's really not it's a triple aim, it's a quadruple aim. We should, or the quintuple aim, with the fourth being, can we make sure our doctors and clinicians and nurses are satisfied with the tools we're giving them in order for them to do their job? And can we ensure, the fifth one being health equity? Can we actually ensure that the people who need healthcare all across this country are capable of getting that healthcare, no matter where they are, whether they live in a rural community, in inner city, or in Bellevue, Washington? And so, when we think about what's really changing right now, and I promise I'll get to this point around personalization, Bill, it's fundamentally around the idea that we have to measure healthcare as a journey. And when we measure it as a transaction, when we measure it as an individual point in time, the primary care visit, the specialist visit, or as I think a gentleman by the name of Eric mentioned in the chat, or as a moment where I'm trying to figure out, is this benefit covered? Do I know whether I can go see a chiropractor, or what is this thing I got in the mail that tells me I owe some money? All of these things are moments in a healthcare journey. And that if we're to think about healthcare as a journey that's experienced by a family, not by an individual, and then we think about the data required to assemble all of the information for that journey, we can now start to think about things like what Mike just talked about, value-based care. Can we, in turn, measure the quality of the outcome? Did we lower A1C levels? Did we improve blood pressure readings? Did we do things that made that population healthier? Did we do it at the same time as improving patient satisfaction? Did we do it at the same time as lowering costs? And that's happening now. And I think increasingly you're seeing health systems, whether it's Providence or others, experiment in this area. You're seeing people particularly in Medicare populations, where there's more and more of this work being done, where we're actually driving value-based care, where we're being measured on those core outcomes. And I think for us, what we're doing at Accolade is we're trying to bring that value proposition to the corporate buyer and telling, 170 million people are covered by corporations today in the United States. Can we deliver a personalized care experience that gives you those outcomes? And not by replacing the existing infrastructure, but by overlaying on that infrastructure, both personalization and the capacity to ensure that you don't fall through the cracks from the transactional components of the system, but that we can follow you through your journey and make sure you get the care that you need. That's happening. Look, I'm more bullish on the future of healthcare in this country in 2022, in part because of all the pain we've experienced in 2020 and 21 that opened up the doors for innovation than I've ever been. And I think you're seeing innovation like my panelists, my fellow panelists here, that they're driving, but that's happening across the industry. That's really oriented towards this idea that we got to think about the journey. We got to think about the longitudinal journey of a family through the system and improve their journey at every step of the path. And I think that's happening more and more today.
Okay, well, that's a good transition to another question. Maybe we could tackle. Oftentimes when you look at the internet and how it disrupted travel, which Raj, you were certainly in the middle of that in a prior company. And how it's disrupted other value chains. What do you think happens here in terms of technology? And we obviously in this value chain have a bunch of middlemen and participants between the patient and ultimately the clinician or the provider. And as a result, it's not a particularly efficient, as you said, journey for some patients. So I'm kind of curious if maybe we could talk a little bit about, how technology could disrupt this. And, I don't know, Raj, if you want to pick up on that, and then we can go to Sara and Mike. But, what are your thoughts on, how this value chain could be optimized, I guess?
Yeah, I think it's happening right now, Bill. I appreciate the way you phrase the question is 100% correct. Everything that stands between the physician, the clinician and their patient runs the risk of creating a lack of efficiency. Now, that said, the system today is complicated, and navigating that system across what many of the highest sort of acuity patients, the ones dealing with multiple chronic conditions, are oftentimes wrestling or managing multiple physicians, multiple clinicians, and managing that across multiple care delivery vehicles. In those instances, figuring out how you can drive that longitudinal story, which goes back to where I started from the last answer. Number one, assemble the data set and ensure that people are getting the care that they need when they need it, ensuring that they are complying with their care and their care plans, and then following through on the next step of their journey. Huge part of the story. And the second part of the story, and so is that fundamentally in service of making our clinicians more efficient? Because a lot of that work can be done with people who are not clinicians, or it can be automated via the use of technology. I think the answer to that is absolutely yes. What we should be doing is elevating our clinicians and giving them the freedom to practice at the highest end of their license, because we're eliminating the work that they don't need to be doing, or we're gathering the data for them so they have it when they need it to deliver the care that they need. And the second part of that story in my mind is very clearly virtualization. Like if you want to solve the health equity problem, it's really hard to get a physician in South Dakota. God forbid you want to find a behavioral health specialist almost anywhere in the country right now. But if you want to find a behavioral health specialist in inner city Detroit, good luck. If you want to find one that's accepting your insurance and is going to see a patient sometime in the next 3 months, I'd say forget it. It's not going to happen. And so solving those problems via virtualization is another part of that journey. And so I agree with the hypothesis of your statement 100%, Bill, that this isn't about creating more middlemen. This is about elevating clinicians by allowing them to practice at the highest end of their license, and doing so both in a way that in 2022 can also be virtually.
Mm-hmm. Great. Mike, what do you think about that value chain, or that chain? I don't know if it's value, but there's certainly a chain involved.
Yeah, Raj and I were joking about this as we came on the show here in prep. We're both new into healthcare, coming from tech backgrounds, and yes, internet has typically destroyed middlemen. You've got a buyer and seller. You build marketplaces. However, in healthcare, it's naive to think that you just have a provider and patient, and there's no other third parties or n number of parties also tangentially involved in that delivery. It's the way that we don't have single payer, and it's not likely to happen anytime soon. And the way that how healthcare gets reimbursed in this country is sort of the starting point towards a lot of this fragmentation and disintermediation. But as was also discussed, you have a polychronic patient, and they need a specialist in this capacity and a specialist in this capacity, and there's no one hospital system or no one provider group that has all that capacity. So you'll start seeing patients in different elements. So the way towards solving that fragmentation problem is all going to be on this data liquidity and APIs and real-time calling for patient health and history and other elements. And there's a lot of investments going on in that. So as Raj suggested, I think there are some elements and investments that are working towards some of that data liquidity that'll make some of these real-time aggregation of data that make the best choice for both the patient and the clinician on recommending the next course of action. I also want to reference on something Raj said, the health equity side. If you work for any type of large employer in this country, pretty much guarantee you're going to have an app that can help you with your diabetes or your behavioral health or some other type of remote care, virtual care offering that helps you. The government, i.e. Medicare and Medicaid, are not reimbursing for those things. So if you're one of those older folks that potentially has a harder time getting into clinical visit, or you're on Medicaid and it's challenging for you on transportation, you're still relegated to these face-to-face visits that might be a number of weeks, months, et cetera, out there. It's inconvenient. There's no options for them. So, when you think health equity, the way towards solving that is to go to digital and virtual tools and capacity and availability. It's not going to solve everything, but the thing with healthcare is it often resorts to the lowest common denominator. Let's make a phone call to everybody because not everyone has a smartphone. Let's send faxes because not everyone has the internet. Like, you can't do that. You have to optimize for the 99% and then just treat the aberrations in a different manner. And I think that's what the world of healthcare delivery needs to move towards here in this country.
Yeah, good. Sara, you're in a health system, so interested in your thoughts on this.
I wholeheartedly agree with everything that Raj and Mike have talked about. I think there are a couple really important kind of areas where there's just a tremendous amount of middleman induced friction that really needs to be adjusted. I think this around self-service in general, and it can mean all sorts of different things, whether it's the self-service that I mentioned originally around booking, but there's also other forms of self-service that are important to take into consideration. So I'll give you all one example that we've been seeing from the lens of the provider. So we've trained our patients and consumers over the last 2 years to engage with us digitally and send us messages and do things like message your provider on MyChart, which is our patient portal. And what that has resulted in is an overwhelming amount of messaging coming in for our providers. There's a huge, folks on the phone may be familiar with it, but it's just this notion of inbox management is now reaching a kind of a critical level for us. And there's a one way to address that and take that friction out, which is to provide the clinicians, if we're thinking about it from the quadruple or quintuple aim lens, with the workflow and the tools that they need to be able to triage and have care teams handle some of those messages, so the clinician doesn't have to do all of it. And there's a lot of value that can be created there. There's also a tremendous amount of value that can be created if we come at it from a self-service lens, which is that why are folks sending clinicians messages in the first place? Maybe they didn't have the content that they needed to get their question answered. Maybe they didn't have the tools that they needed once they received the content to get, to take the next best clinical action or the next best action period. And so, there's my boss who came from Amazon talks about at Amazon, they viewed every interaction with a physical person at Amazon as like if someone called in as a customer service defect because something was missing earlier in the customer journey that resulted in them needing to talk with an individual. So there's a whole host of things that I think, self-service gets to the heart of reducing the middleman and bringing the ends of the value chain together. Another one that Raj referenced is, we force our patients, we force our demand to come to us as opposed to supply to go to demand in a distributed fashion, distributed, multimodal, virtualized, digitally enabled fashion. So that's a huge opportunity. And then there was some reference to this as well, but I think probably one of the kind of single most important kind of domain areas that creates a lot of friction is just around the lack of interoperability between payers and providers and the sharing of data, whether, at all levels, whether it be clinical data, or I'll give another example, provider data. We maintain, there's no single source of truth around provider data. We have our own data about our providers, and all of our payer partners maintain their own stuff in like Excel files, and we have to constantly share them in the most awkward, inefficient, sub-optimized ways. And there's like constant reconciliation that needs to occur, and a whole host of problems that flow from there, like challenges with prior authorization, challenges with other forms of task completion around referrals and stuff. So all that said, I think there's so many opportunities that we can remove a lot of that friction, bring the value chain together, like the ends of the value chain together, even taking into account that, yes, healthcare is complex. It's not just as simple as like build a two-sided marketplace and walk away.
You guys all deal with a lot of data, and one of the issues that I've always observed and there's a question about this too from Ty, that I always observed about the whole space was all these different data formats. Is there any movement afoot or any trend or participant in the value chain that can help drive a more standardized set of data sets that makes it easier to create the interfaces between all these systems? Is there anything going on there that could be a breakthrough? Because it seems like that's, everybody's doing software is going to develop like 25 APIs to tie into all these different data types. Raj, you're obviously dealing with a lot of data, as is Mike, and obviously, Sara, you probably see it, but I don't know, Raj, do you have a thought on that?
Yeah, you said APIs, and I kind of chuckled.
I don't know how many APIs you need.
I wish we were dealing with APIs. A lot of times we're
an API, I guess.
Yeah, we're the data sets are disparate. Sometimes I'll have a conversation with other tech entrepreneurs who are thinking about healthcare, and one of the first things that I'll talk with them about is the investment you have to make in the data infrastructure, whatever the data is required to run your business. We have a particular hypothesis on our business and the data required to go to assemble that information is super expensive. It's extremely expensive because you're not getting APIs where you can automate and grab from the preponderance of the industry. You've got to do a lot of brute force work in order to get scale, and to get scale takes time. And so there are movements afoot. We've seen legislation come from DC around, making claims data available and making it available on a broader basis. We've certainly, as far back as Obamacare, we saw changes in government regulations around making patient records available to patients. Now, doing so at scale is still very difficult. And so when I talk about our platform, one of the things that we decided early was we're going to assemble all this data on behalf of our customers. And then anyone that they want to open that data set up to, meaning partners, and some of those partners are the ones that Mike spoke about earlier. We'll open the data set up to their partners on their behalf, and we'll do so free of charge. Meaning the idea should be open up the infrastructure for data. Mm-hmm. So, I guess I'll give you two answers to the question. Is there work being done? Yeah, I think like really exciting work like what Truveta is doing, or, I mentioned earlier, Jonathan Bush has started a company, and we'll see how it goes, called Xealt, that's doing work. We're doing work on behalf of our customers, and that's, 10 million people now. But so there's I think some shimmers of light and an acknowledgement we're way, way, way far away from where we need to be to allow innovation to really unlock. Boy, can you imagine if we could get our hands on this data in an inexpensive way, how much innovation we'd be running to the industry?
Yeah, great.
I'm going to break in quickly just to let everyone know that we are going to switch to Q&A in about 5 minutes. So if you have questions for any of our speakers, please drop them in the chat right now. And Bill, also just a note that your hands seem to be hitting your microphone. So if you could try to avoid that for our last 15 minutes. That'd be fun.
Okay, sorry.
No worries.
I don't know what I'm hitting it with. Mike, any thoughts on the data question? And we'll go
I mean, when you think about healthcare, you've got the pharmaceutical segment, you've got the provider hospital segment, you've got the insurance segment, you've got the employers, you've got all the apps and devices and different constituent groups out there. So there's no way of normalizing all of that data. And so I think all of us are optimizing the data that we need for conducting our business and operations and improving our customer experience, our patient experience, whatever the capacity is, we're trying to control our world around that. If anyone's going to try and move and broker all of that together, it's going to have to be the government with incentives and fines and penalties and legislation. And we'll see how that happens. And they are making progress because, in the world that we live in, this FHIR standard is this interoperable, data structure that it allows querying the hospital system database for patient records and clinicals and vitals and things like that. And that's driving some standardization, but that's not going to solve the industry problem or the patient problem. Ultimately, all this hits to the patient complexity on how they get care, find care, receive care, pay for care. And that's what the industry needs to solve, kind of going back to that level. And whoever solves that best for individuals and patients and consumers, they're going to start winning market share and driving against that. So, I think the industry almost needs to start taking a look at it from, who's going to deliver the best patient care end to end, or as much components of that care delivery as possible and satisfy the consumer/patient. And then that's going to transform all the data streams necessary.
Sara, do you have any last comment on that? We've got a minute or two.
Oh, I agree with what Mike and Raj talked about.
Okay, good. Well, Barrett, do you want to take over on Q&A then? Or?
Sure, yeah. So our first question comes from Chuck Meyer, as he asks, how does HIPAA interfere with the automation of personal healthcare?
I'll give you a controversial answer.
That's our favorite kind of answer.
HIPAA's a good excuse for people not to share data. And it's just not, by and large, it's not a valid reason for not sharing data across the ecosystem. There's a whole bunch of chatter in the chat right now about we need people to break down the walls of data and data interchange. And I think that's 100% correct. But fundamentally, what HIPAA or any of the standards associated with data security are ultimately geared to do is protect the privacy of the patient and respect their what they're going through from a healthcare perspective and who they want to know about that. Oftentimes, patients are the very people saying, "I want to share my data. I want other physicians and other clinicians to have it." And so I'm oversimplifying the point, but I think when I hear institutions talking about we can't share that data because of HIPAA, I think that's an awfully easy excuse for a reason not to share your information.
Good point. Anyone else before we move on? The next question is coming from Mark Prensky. So Mark, if you could prepare to unmute yourself, that would be great. And by prepare, I mean do it now. Okay, he says, this may be controversial. I hear clinicians being held up very highly in these conversations. There are clearly great clinicians, but how do we know how good the bulk of our clinicians really are? What if they are the problem? I say this as a patient who has had various problems with less than great clinicians and physicians. Should we be working toward evaluating clinicians with technology and replacing them with technology wherever outcomes are better? How much do we need the human to human stuff in the domain of being healthy, and how much can technology do in the bulk of the cases?
Sara, do you want to take that one?
Well, I think there's, I heard kind of two different potential points. There's sort of a quality question.
Right. How do you assess the quality of a clinician versus are there aspects of the process now that could be taken over by?
Yes, definitely. And I think that I'll focus more on that second part, which is like the can things be done by non-humans? And I think the answer is yes. We're starting to get more comfortable with this kind of either assistive, like through AI, for instance, assistive technologies that can do a lot of work that augments a provider and not rely 100% or solely on a provider to do differential diagnosis or triage or other kinds of clinical things. And I think over time, there may be, more of a shift toward fully automating some of those things. And I don't think that's a bad thing. I'm not saying that we need that for, or that it's like a good idea necessarily for complex cancer care, for instance, but there are a lot of different use cases where it is more possible, and that human to human interaction is less essential. There's also just a basic reality that we talked about. There's just not enough providers out there, right? So we have to start moving in the direction of automating certain things. Otherwise, like the workforce challenges are just going to crush us. So yes, I think that there is room for it, but it's not like a switch that we're going to flip overnight. There's sort of a glide path to getting there.
We've had a couple of questions in the same theme, which are around, how do you take care of doctors on the other side of that coin, right? How do you protect doctors from becoming overworked? And Kirk is a healthcare provider, so he had an interesting question.
All right, hold on a second. Yeah, there we are.
And buried in paperwork too. The other issue, my doctor friends have is all the paperwork they have to do.
I think the question that I had it's sort of on the same lines as what you've been talking about before. One of the things that we find in healthcare delivery is that it's the provider-patient relationship, the interaction, the direct relationship has a good half or more of the therapeutic value of the entire healthcare experience. So one of the things you do have to be very careful with in putting technology in between the patient and the practitioner is that you may actually dilute that patient doctor experience. And I maybe you can address how you can not be more harmful to the experience.
Yeah, as we add more information technology, how do we preserve the therapeutic value of the doctor-patient?
I'll try and address that one. I think so clinicians used to be very artisanal and kind of deal with every single scenario with their best judgment, best practice, what they kind of knew in their head that they had memorized. Over time, data's optimized that, and you've got more data, more heuristics to know how to treat patient care. But the complexity of that has led to read about this before a visit, or I want you to take this home and do this, or call me how you're feeling after this. And it's led to very manual and laborious kind of processes on the pre-visit sort of diagnoses, and then on the post-visit care and follow-up and check-in that the recommended therapeutic treatment was providing the effective result. I mean, we've all known the phone tag that we play with doctors and nurses and hospital systems and labs and things like that we just don't have in the rest of our lives. So when you can automate and optimize and use technology solutions around the care delivery. Now, to your question very specifically, like I use this analogy somewhat, Uber. Like, the magical part about Uber is not hopping in some random person's car and getting from A to B. It's the fact that you can press a button, just magically call up a car, and then leave the car without having to pay. So it's the pre and post that is the magical experience there. Whereas in a hospital system, the pre and post is the really, really terrible part of the whole patient experience. It's when you're in front of that clinician that you love it and you have a great satisfaction, but it's all the frustration around that. And you're starting to see more in-patient clinical benefits where you now have a lot of voice automation that's transcribing that doctor-patient relationship. So instead of your doctor spending half the visit typing into their computer keyboard, you're now having automation and voice recognition and AI populate and form fill against that. That's largely why Microsoft spent $20 billion buying Nuance. And so you're starting to see the primacy of that doctor-patient relationship and give more time to that clinician to have that time. I think there's also, it goes a little bit back towards the capitation discussion and insurance discussion. When you're in a fee-for-service business model, you're channeling these 10-minute visits and rushing from patient to patient to patient. And when you're in a value-based care model, you can literally spend hours with that patient if it optimizes their healthcare and reduces the overall spend of care.
Okay, we had a couple of questions that were on a similar theme, so I want to try and merge them a little bit. So Eric Jansen asked, are true case-by-case outcome-driven measurements possible across the scope of all healthcare, specifically, not generally? And are outcome-driven measures the best way to go? If not, what is? And the similar question was from Oliver Dominic, who asked, why are we not pursuing the patient information sharing integration model that the Mayo Clinic has demonstrated for decades is extraordinarily better than the fragmented approach we use now? So broad question about how do you think about measuring clinical outcomes and general care?
Clinical outcomes on a population basis can be measured and there are numerous examples of populations being measured on a population health basis. And so ultimately what that means is we understand the clinical outcomes of each of the individuals in that population, and we can measure that population against other populations to determine if they're receiving the care that they need, and doing so in a cost-effective manner. I mean, I think we have to marry cost and quality together in order to really measure value. That's that's true in any supply chain, and it's very true here. Now, this supply chain is more complicated because we're talking about human life and human health, and therefore the decision making and the balance between cost and quality has to be there have to be good arbiters of that decision making, and those arbiters are oftentimes the payers. So those payers could be employers, it could be payers as in insurance companies, and many health systems are also payers in their own right. And so, so the answer is very clearly that we've seen examples in what I'd call advanced primary care practices, in Medicare Advantage practices, in different populations where we can measure and we can assess them against other populations. The second question, I'll again give you the candid answer. People trying to break down walls of healthcare data have been at it for a long time. And there's a bunch of profit motive associated with why it's difficult to break down those walls. If you want to own a customer in healthcare, one way to do it is to hold on to their information. Now, there's a whole movement afoot to change that and to open up data sets, but Why are we not pursuing it? I think the industry is pursuing it full stop. And the government has tried to regulate this in some way multiple times. But we have fundamentally not yet solved the problem. And the work continues. The work continues from the private sector side of companies trying to break down the walls by getting customers like employers, like what we do at Accolade, to say it's my data, you have to give it to me. And I think the work also happens there is work afoot on both sides of the aisle in DC to try to open up these data sets. It's just proven way more complex because the profit motive has been more innovative than politicians.
Thanks, Raj. I want to take one last question. I think we can fit one more in from Amash Aminari. Amash, I'm sorry if I mispronounced your first name.
No, it's fine. It's a Muche.
Amoche?
Sorry. Oh, you can see me now. Okay. Thanks so much to all the panelists. We're going to ask about how automation, in your view, will change the roles within healthcare, because we've required a lot of expertise from doctors and nurses and specific expertise. But as we've had more automation, like the ability to automate beats per minute or respiration or things like that, right? We realize that less time is spent needing that expertise and more time is spent sort of learning other skills or being an expert in something else. I think there was a case in Philadelphia where they're pushing for radiology nurses to be able to do, anesthetic nurses to be able to do anesthesia by themselves instead of requiring an actual anesthesiologist, which would reduce costs. And they're saying that there's usually not very many complications in those scenarios. And so I imagine when technology comes in, a lot of these kinds of cases will pop up. I was wondering if you guys could speak a little bit about what you guys think would change when it comes to the roles within hospitals and how the future of technology and automation will influence that.
Who wants to grab that one?
I can provide a really high level kind of perspective, which is that I think the theme that you'll see, and you referenced it with the anesthesia nurse, is kind of upskilling and or just working at top of license. I mean, that's really that's what we're striving for, because if you can automate rote tasks and then enable folks, whether it's through augmentation or assistive technologies, to do even more above and beyond what they would typically do, that's a tremendous value proposition for the organization, for our organization. It would be. I think the biggest kind of barrier to potentially that happening is a lot of like cultural changes, a lot of regulatory changes, things like that, that the technology unto itself can only do so much. So I actually think it may, like, the technology itself may do some things to change the roles within systems, but there's like other underlying factors that are going to have a lot more influence. That's my perspective.
All right, we have to wrap up. I want to make sure we give everyone enough time to get to our next session, which is going to be fantastic. Thank you, Sara, Mike, Raj, and Bill. You are amazing. We really appreciate you taking the time out of your busy schedules, actually making and building these products, which we know requires a lot of time and attention, to come and talk to us about making and building these products and bringing your perspective. So hope to see you over there.
All right, Mike and Raj, thank you.
Thank you so much, everyone.
Thanks,
Thank
you guys.
you.